And this is just showing the same things from Birmingham, the reoperative rates after an ileorectal anastomosis or a total proctocolectomy. The next that people have looked at is the length of the resection margin. And this was an interesting paper from 1977, a retrospective review of 186 patients having surgery over a 12-year period, and this was in Scandinavia. And they showed that if you had a radical resection, that the recurrence rate was 29% as opposed to 84% after a non-radical resection. And you can see it was 1977 when we were all geared up because we were curing cancer and we were going to cure IBD or Crohn's disease as well. Well, what's interesting about this study is it was a comparison of one hospital versus another hospital. So the likelihood of patient selection biases was large. It wasn't analyzed actuarially. And the bottom line, it probably doesn't make biological sense because we know that Crohn's is a pan-intestinal disease. But I like to show this study anyway, just to show how far we've come actually in trying to answer these questions. And in fact, Victor Fazio looked at this and published quite a good study, a randomized controlled trial where patients were randomized to a limited 2 centimeter margin versus 12 centimeter margins, long follow-up of 55 months, and the recurrence rates were 33% versus 28.6%. And this was not statistically significant. So I think that surgeons certainly believe this, and here's the evidence. What about histology of the resection margin? Another thing that's gone through a phase of people being interested in it. And there are lots of studies, and I'm just showing one study here from the Cleveland Clinic, and you can see that category 4 meant that there was macroscopic disease left behind, and category 1 was normal, and there really wasn't any significant difference. So again, frozen sections are out, looking at the resection margin, except to make sure that all the macroscopic disease is removed. That's of no value also. And then what's come into sort of the flavor of the day is the type of the anastomosis. And the rationale for this is that, as I said, recurrence is decreased in individuals who have an ileostomy as opposed to an anastomosis, or if one does an anastomosis and it's defunctioned with an ileostomy, that the recurrence rate is significantly decreased. Furthermore, there's a study, quite a nice study, that was looked at infusing stool or feces down the distal limb of a loop ileostomy, and they were able to show that there was evidence of microscopic inflammatory changes within 7 days of infusing stool into the defunctioned bowel. So it suggests that the fecal stream is necessary to develop recurrent disease, and that's also supported that antibiotic therapy seems to decrease the risk of recurrence. Furthermore, that people have observed that most recurrences occur in the pre-anastomotic area, and so it's been hypothesized that something may be going on at the anastomosis, and that there may be stasis of the stool proximal to the anastomosis, which increases the likelihood of recurrence in that pre-anastomotic area. Furthermore, people have gone on to hypothesize then that if you do a wide side-to-side ileocolic anastomosis as opposed to an end-to-end anastomosis, that the risk of recurrence may be decreased. So in fact, we put together a group, and we had 17 centers in Canada, the US, and UK, the Canadian-American Surgical Crohn's Disease Trial, to answer that question, and whether recurrence rates would be lower doing a stapled side-to-side anastomosis as opposed to an end-to-end hand-sewn anastomosis. We included patients who just had terminal ileal and right colon colonic disease and were scheduled for an elective ileocolic resection. We excluded them if they had disease elsewhere, either at the time or previously, if they had significant perianal disease, and if they were on medications for Crohn's disease that could not be discontinued. And it was a pretty simple, straightforward design that we randomized them either to hand-sewn end-to-end anastomosis or a stapled side-to-side anastomosis. And you might say, well, why did we choose a hand-sewn end-to-end versus a stapled side-to-side? And would we know whether it was the hand-sewing or the staple or the end-to-end and the staple or the side-to-side? And we really took a pragmatic approach to it, and that is that generally surgeons would do a hand-sewn end-to-end anastomosis, or they do a stapled side-to-side anastomosis. So we really wanted to answer that management question rather than an efficacy question per se. We colonoscoped all of the patients at 12 months or sooner if they developed symptoms. We did CDAI and IBD-Qs on the patients at various intervals, and blood work including C-reactive protein. And our primary outcome measure was endoscopic recurrence, and for that we just looked at the recurrence limited to the pre-anastomotic area, and we used a modified Rutgers score to greater than an I2 score, meaning that there were actually ulcerations in that segment. We also looked at symptomatic recurrence, and for that we defined it as symptoms severe enough to warrant medical or surgical treatment plus endoscopic evidence of disease. And we had a blinded adjudication committee that looked at all of the outcomes. And I'll just say that our primary outcome was endoscopic recurrence, and the study was powered so that we would show a 20% difference in rate. So we hypothesized in the end-to-end group that it would be 40%, and we wanted to see a 20% difference. And you might say, well, that's a very big difference. Why did you choose such a big difference? The bottom line really is because we were concerned about patient accrual, but the other reason was that we thought that the more clinically relevant was the symptomatic recurrence rate, and if we didn't show a large difference in endoscopic rate, then probably it would not be of any benefit. So we randomized 171 patients. One patient was excluded, and we had 86 in the end-to-end group and 84 in the side-to-side group. There were some patients who refused their 12-month endoscopy, so there were 73 patients in the end-to-end group versus the side-to-side anastomosis group. There were 66, so in the final tally that we could analyze for our primary output endpoint. So here you can see that these were probably fairly typical patients who have terminal ileal disease. Interestingly, a larger percentage than the normal population were smokers, 37% and 31%. We started this study just as people were starting to do laparoscopic surgery, and so you can see about 50% were done laparoscopically and 50% open. About a third of them, the indication was fistula or abscess, and 17% had another procedure. So what we mean by that, they couldn't have other disease, but if they had a fistula, say, into their sigmoid colon, we could take out a piece of colon and they were still eligible. Not surprisingly, that those in the stapled side-to-side group, that the mean time to do the anastomosis was shorter, and the mean duration of the operation was shorter in that group. I think what is really interesting for surgeons perhaps is that the anastomotic leak rate was 7% in both of the groups. And I think as surgeons we would think that the leak rate after an ileocolic resection would be much lower than that.